Yeah, so one of the pathophysiologies of PCOS is that these patients have insulin resistance, especially at the level of the ovary. Not all of them have peripheral insulin resistance, but because we have insulin sensitivity in all of our different tissues, so in the muscle, in the fat, in the liver, in the ovaries. But the problem is that PCOS patients are at an increased risk of developing gestational diabetes, which is a disease of insulin resistance. Now, pregnancy is an interesting thing because this is the one time in our life where we develop physiologic insulin resistance. So let me kind of break this down. When you get pregnant in the first trimester of pregnancy, your pancreas starts increasing insulin production by about 30%. So it starts putting
Mm.
out more insulin into the body. Some of these patients are already coming into pregnancy, what we call hyperinsulinemic. They're already making a ton of insulin in an attempt to make the blood sugars normal. And so now this may exacerbate the hyperinsulinemia. Now, in the first trimester, though, the insulin sensitivity tends to be better. It's more of an anabolic state for the body. It's trying to grow. It's storage of energy for this growing baby. And then as we transition into the second and the third trimester, as this placenta starts to develop, there's a lot of other hormones that are involved with growing a pregnancy. So not only robust amounts of estrogen and progesterone, but we start to see HCG rise. We see something called human placental lactogen. So there's some hormonal changes that happen that the placenta is secreting hormones that increase physiologic insulin resistance. And so the question would be is why would you want to develop insulin resistance in pregnancy? A lot of this is the way that the body shunts energy to the baby. So as the pregnancy
Mm.
progresses, we want a large amount of glucose and fatty acids available to cross the placenta to go to fetal use for the fuel. I mean, you can imagine the metabolic um, requirements of literally growing a human inside someone's belly. It requires a lot of fuel. And so these physiologic changes in the hormones basically assure that there is a free flow of tons of energy, free fatty acids and glucose. Now, the problem is this could come with ramifications for the mother. And that's why we test for gestational diabetes. The caveat here with gestational diabetes is we have cutoffs for glucose levels to diagnose it. It can be done with a 1 hour glucose tolerance challenge. It can be done with a 3 hour test, or sometimes these patients actually have prediabetes or even type 2 diabetes that's been undiagnosed. So you can check things like a hemoglobin A1C. The trouble in pregnancy is it's falsely lowered due to the rapid turnover of red blood cells in pregnancy. But some of
Mm.
these patients, if these tests are done in the first trimester of pregnancy, that's actually prediabetes or type 2 diabetes. That's not gestational. Gestational is diagnosed at generally 24 to 28 weeks of gestation as we're nearing that third trimester. But the other thing I really wanted to hit on here is that even if a person has normal blood glucose levels in pregnancy, let's say they pass the glucose test, let's say they're even checking their blood sugars in pregnancy and they have normal glucose levels. The question we always have to ask in the back of our mind is at the cost of what amount of insulin? Because we know that pregnancy is a hyperinsulinemic state. And so if you have even more insulin that's being secreted, to make the blood sugars normal, the baby's at risk, the mom's at risk, she's at risk for high blood pressure, for preeclampsia, and the baby long term in pregnancy, there's something called fetal programming or epigenetic changes that happen. So literally the way that the mom eats, the stressors and things that she's exposed to can actually modify the DNA, kind of turn off light switches on and off. That's kind of how I like to um, paint that picture a little bit because it's sometimes hard to understand how you could alter your baby's DNA, but it's basically kind of turning these light switches on and off. And we know that patients with hyperinsulinemia and hyperglycemia in pregnancy, their babies are at an increased risk for obesity, type 2 diabetes, cardiovascular disease over their lifetime. So even if you make it through the pregnancy safely and the glucose levels look normal, there could still be changes related to hyperinsulinemia that could be affecting, the baby and the offspring of that mother. So it's super important that these are controlled during pregnancy.